Good day, colleagues. My name is Dr. Balwinder Singh. I'm a consultant and assistant professor in the Department of Psychiatry at Mayo Clinic in Rochester, Minnesota. It's my pleasure to give a talk on this important topic. The title of my talk today is Anterior Cingulate Cortex, GABA Normalization After Ketamine Treatment for Treatment-Resistant Depression, a Post-Hoc Analysis. Here are my disclosures. Now let's start with treatment-resistant depression. As we all know, and there have been most of the guidelines, they recommend treatment-resistant or define treatment-resistant depression as patients who had tried at least two different antidepressants of adequate dosage and duration, which is usually considered about 6 to 8 weeks in the current episode of depression. As we all know, the STAR-D trial showed that only 1/3 of patients experience full symptomatic remission and 1/3 do not even respond to antidepressant despite multiple medication trials, thus suggests the need for urgent need for faster acting antidepressant to reduce patient suffering. Now, ketamine is one such option which has shown a lot of data in last 2 decades. It's FDA approved as a general anesthetic and for procedural sedation. It's a Schedule III substance. Mechanistically, it's a non-competitive antagonist at NMDA receptors. There's also data suggesting it acts on AMPA, sigma-1, and mu opioid receptors and different other pathways as well. Single intravenous infusion at subanesthetic dosage 0.5 milligram per kg body weight is the most common one, can produce rapid antidepressant effect within 24 hours. However, intravenous racemic ketamine has no FDA approval. It does have abuse liability. There is data suggesting in an ketamine abuser it can contribute to cystitis, and animal data suggesting even cognitive impairment. The S enantiomer of ketamine, or S-ketamine, is FDA approved now in the United States in conjunction with an oral antidepressant for treatment-resistant depression and also for depressive symptoms in major depressive disorder and acute suicidal ideation or self-harm behavior. However, the antidepressant mechanism of action of ketamine remain an active area of study. Now, magnetic resonance spectroscopy provides us this unique platform where we can investigate in vivo brain biochemistry and biochemical mechanisms of drug actions. Anterior cingulate cortex is one such area which has shown to be associated with emotion processing and regulation and has been investigated in prior studies related to depression, clinical outcomes, and antidepressant treatment in major depressive disorder. Now, in major depressive disorder, there are studies which have shown that patients can have reduced glutamate, GLX, or GABA in the anterior cingulate cortex. There are studies suggesting that increasing GABA or normalizing GABA could be a potential mechanism of action, which has shown to be with some antidepressants or transcranial magnetic stimulation and even ECT. So my research here is focused on trying to see if ketamine is involving the GABA here as well. Now, there are limitations with the conventional magnetic resonance spectroscopy. We usually, when we do MRS studies, we look at limited time points, how to measure metabolites at baseline, endpoints. There's a recent study where they did metabolite assessment at every 13 minutes, but there's lack of continuous measure during the scan. Now, sliding window functional MRS. Now, that's a novel methodology which can capture dynamic changes in central metabolites during the infusion. And so we utilize this novel technology in our study, and we normalize each metabolites to their individual baseline level, and percentage changes were used in our initial analysis. Study design. So this was an open label feasibility trial where we included adult patients with non-psychotic, moderately severe to severe treatment-resistant major depressive disorder. Patients received the IV racemic ketamine infusion while they're in the MRI scanner. For the first 13 minutes, we did the structural MRI followed by the fMRS during the next 40 minutes when patients received the infusion, where we could continuously measure the ACC, GABA, glutamate, and GLX level. We monitored patients for 60 minutes after the infusion, and we also collected blood at 4 time points to measure the peripheral GABA and glutamate levels as well in all the samples for fasting. Here are results. We had 7 patients for which we had the available imaging data. It was the mean age was 45. It's a middle age. Mean duration of current depression episode of depression was about 6 years. So pretty sick group of patient, and they had 86% had comorbid anxiety disorder. Our remission rate was 43% at 24 hours. Now these are our imaging findings from our initial papers, where we showed that if you look at this figure, on the x-axis we're looking at time points, and the y-axis we're looking at percentage change in GABA during those 40 minutes when patients were receiving the intravenous infusion. So if we look here at this red line, these are the patients who remitted with ketamine, and this, if you focus on this blue line, these are the patients who did not remit with ketamine. And we could see that in the remitters during that 40-minute infusion, within that 20 minutes, we start to notice a significant surge in GABA level. Although it started to go down, it still stayed pretty elevated or significantly higher as compared to non-remitters. So what we showed, even with this preliminary data, that there's a increase in peak or even average ACC GABA during ketamine infusion, which was even associated with the next day remission and correlated to degree of degree of clinical improvement, suggesting that ketamine actively engages the target of central ACC GABA. We did not notice any relationship between ketamine level and treatment response, although there was some borderline significance between change in central GABA with the peripheral GABA. It was not statistically significant. Now, once we published that study, we started thinking, well, what could have led to the change in GABA in the remitters versus another? And so falling back to the earlier data where we have seen that antidepressant, TMS, even ECT sort of normalizes the GABA deficit. So we came with this hypothesis that probably the patients who remitted, they probably had a much lower level of GABA to begin with, and did ketamine just normalize that? So we went with that hypothesis. Prior studies have shown, the low GABAergic tone in major depression drives glutamate elevation, so both low GABA and increased glutamate could be targets for pharmacotherapy. So this was our hypothesis. Methods. So again, we as mentioned earlier, we used fMRS at 3 Tesla using the megapress sequence. Now, for this analysis, we used creatine as a normalized reference. So we measured change in GABA. We also measured the change in GABA and creatine, as that has been shown in some of the in the literature to be a more effective, a more robust marker for change. We used standard statistical techniques. For the endpoint, our hypothesis was that the GABA measure would be equivalent between the two groups. Now, these are our findings, which are recently published in the Psychiatry Research Neuroimaging. So the figure on the left shows, here we look at the GABA, here we look at the GABA creatine ratio. So here, as we see at baseline, the yellow group of patients were remitter. They had a much lower GABA level as compared to non-remitters. And all of the remitters, we noticed an increase in GABA, whereas non-remitters, we did not notice any change or mild decrease, but it was not statistically significant. And with GABA creatine ratio, we saw the seminal findings. The figure on the right shows more condensed data, where we look at on the x-axis at the baseline and end of infusion, and the y-axis GABA level. So at baseline, there was significant, so non-remitters had significantly higher GABA level as compared to remitters, and at endpoint, there was no difference. Okay, so thus this hypothesis generating study suggests that ketamine probably normalizes GABA deficit among TRD patients who remitted with ketamine infusion, with the caveat that we did not have a placebo group. There's a potential; it could be a potential pathway to neuronal excitability. It actively engages central ACC GABA. Limitations: a very small sample size study, open label study design, patient continued their medication, so we do not know the impact of those, although we um, excluded patients who are on any GABAergic medication such as gabapentin or any other medication which impacts GABA level. From a discussion standpoint, so this study provides evidence for a novel central biomarker finding. We are involving that ketamine is probably involving ACC GABA level, which is associated with remission in TRD patient. Ketamine potentially normalizes GABA deficits among remitters. While peripheral biomarkers are less expensive and with greater generalizability, we do not have clear data if they are an accurate assessment of central GABAergic and glutamatergic function related to ketamine. I think that data needs to be explored further. These are novel findings that need to be replicated in a larger sample size. Future direction, as I said, replicate in larger cohort with an increased sample size. We'd also like to include patients with bipolar depression and do more placebo-controlled studies so we can go with this hypothesis. And if we can prove that in the placebo-controlled study, we're looking at a probable biomarker. And also to look at the potential metabolomic analysis for these patients and looking at some GABA acylcarnitine changes which could correlate and has been shown in some of the earlier studies. Here, my acknowledgements are like to thank my mentors, Dr. Mark Fry, and Dr. John Port, and Rima Kadura-Dag, who's my metabolomics mentor, and my team here at Mayo. And thank you to all the patients, and thank you to my department who supported this research. Thanks.